So today we are trying to focus more on the EP techniques, the electrophysiology techniques, how to differentiate the supraventricular tachycardias actually. So it's a very common thing which we keep on coming across, supraventricular tachycardia. So a lot of times it can be pretty tricky using the clinical skills which we all are having. So a basic question comes is how can we differentiate them? So there are very systematic approaches for that. So initially you should always try to see for the what are the baseline findings during the tachycardia, the initiation, the termination, the maneuvers which you are trying to do during the tachycardia as well. What kind of history does it have? The patient, for example, if someone is telling, okay, so that also is going to give you a lot of clues. So today we are trying to focus on this topic, which we already said about. So if we will try to look carefully, the supraventricular tachycardias on a rough basis, you can try to classify them into AVN orthodromic reentry tachycardia, or the atrial tachycardia. So of course, if you are able to see a ventricular pre-excitation is there, so majority of the times it is going to have orthodromic reentry tachycardia, right? However, 10% of those patients can also be having it AVNRT in fact. However, so it's not always like this. If someone is having a pre-excitation, it is you have to be you are dealing with a pathway. So a lot of times it is innocent bystander as well. So that also tends to happen. In fact, in 3% of them can have atrial tachycardia. Okay. Similarly, whenever you have already come across dual AV node pathway as well. So in fact, 6% of them can have accessory pathways as well involved. And up to 8% of them atrial tachycardias, in fact. So similarly, whenever you're trying to do the parahesian pacing, we will deal about it in the end, especially. So whenever you're trying to deal, so yes, 83% of the times you will be able to pick up the orthodromic reentry tachycardia. However, 17% of the times it is, even for AVNRT. And similarly, we'll show the response of the RV pacing similarly when there is a VA block as well, but the VA block is more than 600 milliseconds. There are equal times, however, with higher chances for atrial tachycardia compared to the AVNRT. However, on an overall incidence basis, we all are aware the most common tachycardia is dual AV node pathways. After that is the one where it comes is for the accessory pathways, in fact. So one of the key things which I really learned during my EP training as well, that SVT ablation, it must be precise, elegant, classy, and an artwork. So one should take every opportunity to fully appreciate all aspects before the dragon is killed. Burning while learning certainly does not belong here. Okay? So to ablate is not a difficult thing, I believe. But what to ablate, where to ablate, that is the one tricky thing, okay? With my due respect for our technicians who tend to assist us and all. So what happens, what is the difference otherwise between you and the technician, okay? Because you should be able to appreciate the logic, the maneuvers, what you're going to do during this procedure, not just going and burning over there. And that's what a lot of people are doing. I'm aware those interventional cardiologists who are just trying to jump into the EP without a systematic training, in fact. So that's why that training is important, to literally bring out the man from a boy, the lady from a girl. So that is the thing. So that's what we will try to deal about. So this chart will already seem pretty familiar. So in some of my earlier sessions, I have already dealt about it as well. So this is what you try to do is whenever, so for example, depending on the VA interval and on the RV pacing, what are the things do you come across and how do you deal with that? So it's really beautifully explained, like how to differentiate between atrial tachycardia AVN RT, and the atrial tachycardia as well. Okay, so that is the really important thing. I would really like you all to be master in this technique as well. So there will be other things as well which I'm going to show you. So other than this, so what are the things? So as I said it, these are the different tachycardias. So whenever you're trying to deal with that as well, how will you differentiate between them? So this really assumes a lot of importance. So as I had already said it, so if you come across the septal VA interval is less than 70 milliseconds, you are ruling out a orthodromic reentry tachycardia, okay? So similarly, so then you try to look for the pattern of activation. So in the pattern of activation, when you're having a look, if there's eccentric pattern of activation, so that is the time when you look or you rule it out as AVN RT. Similarly, if when you're during the pacing inverse, you are able to induce a AV block and the tachycardia terminates. So of course, you are ruling out atrial tachycardia. And why is that? Because atrial tachycardia need not depend upon the AV conduction. Similarly, when you are able to terminate tachycardia with V pace and without A. So similarly, then again you rule out a atrial tachycardia. So whenever you're doing a V pace, RV pacing, so then, for example, for the AVN RT, you get his V response. However, for the orthodromic reentry tachycardia, you will be getting V response. Do you understand? So the his is the one which will be making the difference for the AVN RT and ORT. Then the question comes is, how about the tachycardia cycle length? So if the sinus tachycardia cycle length is more than 500 milliseconds, so definitely you are able to rule out as atrial tachycardia, because atrial tachycardias are pretty faster, in fact. So I already said it. Similarly, the AV block during the SV tachycardia is the one for which is going to rule out the ORT. And if you're able to induce a tachycardia with a critical AH, that is the time you rule out the atrial tachycardia, of course, because it's not dependent upon that. Similarly, if you're able to isolate the V, when the V is isolated and the tachycardia still is persisting, that's what you try to rule it out as ORT. Okay, so now you know quite a lot of things how to rule out, but how to rule in the things. So for example, if you get some finding, you are able to tell, okay, that's the diagnosis I've been looking out for. For example, if the septal V interval is going to be less than 70 milliseconds, highly likely that is a AVN RT, the typical AVN RT, of course. Really, atrial tachycardia can also be there. Similarly, with a bundle branch block development, the VA interval increases by 20 milliseconds. So that is again a predictive for orthodromic reentry tachycardia. And the another key thing is, like, if whenever you're doing a ventricular pacing with his effective refractory period, okay, and there is no A, of course, you are able to rule out the orthodromic reentry tachycardia. And similarly, so the cycle length, I had already said it, if it is more than 500 milliseconds, you are able to rule out even AVN RT as well. Okay, so for the AVN RT, the cycle length is less than 500 milliseconds. Why is that? Try to think about it. The re-entry circuit, for example, for the AVN RT is quite a lot smaller. So that is why tachycardia can be quite a lot bigger. And that's the reason, if the cycle length, if it is more than, the tachycardia cycle length is more than 500 milliseconds, you are able to rule out AVN RT. So what is happening? So I will try to give you some examples as well. Let's try to have a look on some of the examples. What is actually happening over here? So for example, if you look carefully, especially on the surface ECG, seems like some pre-excitation is present, right? Then you try to put up those intracardiac catheters. So the HIS catheter is there. Then comes the coronary sinus catheters, you have put it up, the RV and the stimulating. Okay. Then what do you notice over here? So in the first beat and the second beat, there's some difference, right? Isn't it? I think all of you will agree over here. So in the second beat and the third beat, there's more of pre-excitation. Okay. So the pre-excitation is there. So that is why when you will be looking at the HV interval, HV interval, HV interval, what is happening? So from the H to the surface V, it's not even positive. So for example, over here, H is in front of the V, okay? The surface QRS. It's in positive. However, over here, if you look carefully, the surface origin of the V is in front of the his. So this is again characteristic of, so here the HV is minus 15 milliseconds. So what is it characteristic for? So in fact, almost always it is going to predict is ORT, orthodromic reinjury tachycardia. Similarly, now try to look carefully on this slide. So what is happening is, so we have already done these measurements to help everyone. So what is happening over here? The AH interval we have taken, okay? So the AH interval was here, and then in the next slide, there's a jump of more than 97 milliseconds. So what is happening over here? So there's an AH jump. More than 50 milliseconds is the AH jump. So it is quite a lot predictive for AVN. Quite a lot I'm saying is 86%, because there are exceptions. EP is the field of exceptions. There are always exceptions, okay? And I don't want to give you a lot of exception criteria and all, because you're going to start confusing right now. First thing is, know the common things. Common things are commonly correct. Rare things are rarely correct. So right now I would like you to guys and girls, of course, all my students, to focus on the basics first. Let's try to learn all those things. If we are able to learn, we will be able to understand a lot of other things as well. Now, so whenever we are doing a decremental VA conduction, so what is decremental VA conduction? Okay, so what is happening is, whenever we are seeing over here, if you look carefully, that's why the marking has also been done. So over here, the interval has been taken, okay? So the first cursor is lying on the V. The second one is on the A. So the VA is getting prolonged. So this is what is called as a decremental VA conduction. So this is again a characteristic for the nodal response. So then what is happening in this is, we are trying to pace from the RV at 700 milliseconds, right? So what is happening over here? If you look carefully. So this is again characteristic for the ORTs, but only just 5%. So as I said it, that's why. So you should try to look out for the most common things, which is most commonly correct. So what is happening over here is, the pacing is going on from the RV. Sorry. Yeah. So you are able to notice the A as well, VA, VA. And then later on, when you're pacing, there's no A over here. There's no A over here. Later on, the A starts. Yeah. So these are some of the, so especially a lot of times for the accessory pathway, whenever you're trying to do, otherwise, I have had more than 10 papers as well about the usage of adenosine after AF ablation for seeing the dominant reconduction. So if you're interested in that as well, so you can see that. And I also has been the reviewer for the Lancet, in fact, for the advice trial. So the adenosine can also be used in other things as well. So what about the parahesian pacing? So parahesian pacing is also very important. So if you look over here, these two intervals, so the interval over here, what is the two things which is obvious? If you look on the surface ECG, this is wider, this is narrower. However, if you look at these two intervals, this is slightly longer over here, right? So this is parahesian negative. We'll discuss more about it in some other session for sure. Okay, so what is now happening over here? So this is what is called as the for the accessory pathway response. So that is the other reason why a lot of, there are some of the other maneuvers which we try to do is the differential RV pacing. So of course, this is again dependent upon the entrainment. So either pace in the RV apex, otherwise in the base. So if you're going to be there in the apex, so if something is there which is closer by, you will be able to entrain it and also pace it as well. However, of course, if you're far away into the base, you may not be able to pace that. Yeah, so I hope this concept is clear as well. So what is happening is over here, if you look carefully, so this is actually the schematic representation of response to the parahesian pacing between conduction over the AV node alone, okay, and conduction over an accessory pathway, and conduction over the AV node and the accessory pathway combined, in fact. So this is what is called as the nodal response. So as I was telling you about those pacing from the RV apex and pacing from the RV base. So this was again a very beautiful paper with a beautiful summary as well. So here it is positive for the posteroceptal accessory pathway, in fact. So now coming to what are the things which we can do during the tachycardia. Yeah. So during the tachycardia, we already explained that if septal VA interval is less than 70, most commonly it will be AVN RT. If the eccentric atrial activation is present, highly likely it will be orthodromic reentry tachycardia. And these characteristics, we have already said it earlier. So what is happening over here? So this is already a tachycardia, which is going on with a septal VA interval which is less than 70 milliseconds. So what can you rule out if you will get this? So of course it rules out ORT. Then in this another tachycardia, all these catheters are already present. So if you are looking carefully at the intracardiac ECG, so that's why cycle length has also been put up over here. So this is what is called as the eccentric atrial activation. What do you rule out? So what is the tachycardia? It is not. So you rule out AVNRT, right? So what is the mechanism over here? So what is really happening over here? So if you're going to look carefully, so these are the surface V's. However, if we'll start going inside the intracardiac ECGs, we start looking the HRA, okay. So there is like 2:1 conduction. So similarly, if we'll be going into this his as well. So in the his as well, so there's a re-entry what it looks like, right? So there's a his potential before all these A's as well. So that's what is reflected also in the coronary sinus. There's a P, there's P. So there's like 2:1. So this is what is called as a AVNRT. Okay. So that's why these maneuvers are important, because I have come across a lot of people do tend to easily get confused as well what is happening over here. So this is what is so the same tachycardia is over here, continuing over here, right? So what you're trying to do over here is you're trying to give some atrial extras, and over here you try to do was RV pacing. So when you try to do the RV pacing, you saw the response was V, A, his V response. So then again, this is the one which is going to go in favor of typical AVNRT, right? I hope I'm clear enough. So now coming to the other things, what can we do? So what are the maneuvers which can be done during the tachycardia? So now we'll try to show you. So for example, this tachycardia is going on, yeah? So we can see there's small VA interval, short VA, in fact less than 70 milliseconds. So what we can do over here? So what we try to do over here is we can do two things. One is the pacing, RV pacing, we did it, and we try to stop and see what is the response. So which we saw already over here was, and from the R right atrium as well, you can do the pacing. Also from the CS as well, you can do the pacing during the tachycardia, and also from the right ventricle as well. Yeah. So what does this tell you over here? This tachycardia. So right now, this is the tachycardia. Every patient tells its own diagnosis. The only thing is we should be able to know what is happening. So what is happening over here? So I'll try to give you some more hints as well. I think we'll try to discuss more about it in the end. So this is the thing which is trying to tell you about the SVT induction. So as you can notice over here, these are the S1 and S2 extras which is being given. Okay. So if you look carefully at the AH interval, so there is a jump, right? So there is a jump, and then the short VA interval tachycardia is going on. So what is happening? So over here, now see, I'm trying to give you more hints so that you should try to recognize those hints. And in the end, we will come back again to these questions. And the end, trying to conclude after the theory portion is over. You all are going to get a quiz session as well at the end, in which we will try to discuss about each and every answer in detail, in fact. So over here, what has been done? Here's the refractory. PVC has been given. And then, are you able to pull in or pull out? So this is the importance of the his refractory PVC, which I was telling you. So that is why you try to keep on measuring the A, and then from the stem to the his, is it less than 30 or not? If it is going to be less than 30, yes, you are in the zone of the his, and then you try to see for the AA interval, is it same or not? So if it is going to be, are you able to pull in or not? So on the basis of that only, you are able to tell the his refractory PVC. Did it affect, what is it able to pull in or not, in fact? And on the basis of that, you further differentiate for the tachycardia. So now what is happening over here? So already the headline is already here, in fact. You're trying to do is the RV pacing. RV pacing is being done over here during the tachycardia. Yeah. But during the RV pacing, what do you notice? What is happening over here? So you are able to see is V, A. I can't see any his, in fact. VA. So what do you notice? VAAV, right? VAAV. And the other thing always is whenever you're trying to paste from the RV, trying to differentiate it from the pseudo VAAV response, you should always try to see the VV intervals, the AA intervals, VV intervals, AA intervals. Are you able to entrain it or not? And then you should try to see too. So this is another important thing, trying to differentiate between the pseudo VAAV response and the real VAAV response. So this is something very important I would like to really emphasize to everyone. So, and for the atrial tachycardia, you all are very much aware what happens is you will be able to get is VAAV response, right? So now the other concept, important concept, which is there is the fusion during the right-sided orthodromic reintegratory tachycardia. So what happens fusion with the ventricular overdrive pacing during the orthodromic reintegratory tachycardia in a patient with right free wall accessory pathway? Yeah. So before the ventricular overpacing, the ventricles are fully depolarized by the tachycardia wavefront via the AV node. And the ventricular overdrive pacing results in fusion between the pacing wavefront, which is shown in black, and the tachycardia wavefront, which is shown in white with black stippling. And with continued pacing, there's progressive fusion with increased amount of ventricular myocardium depolarized by the pacing wavefront. And if you look carefully in the second figure, B, so what happens is this retrograde limb of the tachycardia eventually is driven by paced wavefront and a stable collision point results. This stable point of collision is located below the His bundle, and that is the one which results in the constant QRS fusion. So, so what happens during the left lateral ORT and the AVN RT? So what is happening is when there is a first beat of stable morphology during ventricular overdrive pacing in a patient with the first figure, which is for the ORT and a left lateral accessory pathway, and the second figure, which is about the AVN RT. The stable collision point with a left lateral accessory pathway is above the His bundle and results in a fully paced QRS morphology because the pathway is far from the pacing site because the ventricles are part of the tachycardia circuit in the orthodromic reentry tachycardia, and tachycardia must be reset coincident with or without before the first beat with a stable QRS morphology. And in fact, in AVN RT, the first beat of stable morphology, which is the end of the transition zone, is fully paced but does not reset the tachycardia circuit. Yeah, and that's why the pacing wavefront must first penetrate the His bundle and the lower common pathway before it resets the tachycardia circuit. And this is the reason why. So a lot of times, so this is the orthodromic reentry tachycardia. So what is happening over here? There's fusion over here. So what is the concept for that? So this is a OIT in a patient with a decremental conducting septal accessory pathway. And the atrial timing is delayed with the first beat, of RV pacing, which is diagnostic of ORT. And the stim to atrial interval, what is the SA interval, becomes fixed during the transition zone. Yeah, so that's what transition zone is over here. So there are two beats before SM1. Yeah. So in the second part, so which is this figure, I'm going to show you in this. So what is happening in this is there's atypical AVN RT, and the atrial timing is not altered, and the SA does not become fixed until SM3 and SM4, respectively. Well, after the end of the TZ, yeah, that is the transition zone. So that is why if you look carefully, F, I mean, it refers to the fusion between the basic wavefront and the tachycardia circuit, and SM is the beat of stable morphology. So in this as well, what happens is two things we all should be always keep it in our mind is atypical AVN RT, the atrial timing is not altered and the SA does not become fixed until the SM3 and SM4 respectively, and that too well after the end of the transition zone in fact. So if whenever we will be looking out for if there is a long RP, supraventricular tachycardia, so the differential diagnosis is most commonly atypical AVN RT and of course a septal ORT as well. So if whenever we are trying to look out about the intervals, so more than 85 milliseconds is the one which is for atypical AVN RT. However, if the RP interval, if it is less than 85 milliseconds, most commonly it goes in favor for the septal ORT in fact. Similarly, this is a beautiful and very important scatter plot which is showing the mean value of the standard deviation for the PPI minus tachycardia cycle length. So in the tachycardia cycle length, if it is more than 115 milliseconds, it is going to favor the atypical AVN RT. Yeah, And if it is less than that, septal ORTs. So now, so what is happening over here is a basic question comes is the RV forming a part of the SVT circuit or not? So this is taken from a really beautiful paper. So during the entrainment of the ORT using a right posteroseptal bypass tract from the RV apex at a cycle length of 440 milliseconds. So what you are able to see is when you are trying to look is post pacing interval is 550 and the tachycardia cycle length is 470. So this comes like 50 minus 470 is going to be like nearly 80 milliseconds in fact. So that's why RV, because RV becomes a part of the SVT circuit. But however, in this, if we are going to look carefully, because you're trying to entrain it for AVN RT, and then when you will post pacing interval minus tachycardia cycle length, 690 minus 540 is going to be more than quite a lot more than 110 milliseconds, right? So this is almost like 150 milliseconds. So of course, this will become like a AVN RT, in fact, atypical AVN RT. So what is the concept for the entrainment mapping? Entrainment mapping is if you're going to be closer to a source or circuit, you will be able to affect it well, right? However, farther you're going to be there from that, you may not be able to do. So for example, right now in this figure, you're trying to take 3 points, A, B, and E. So if you're going to be over here, of course, you will be, if you're doing two pacing maneuvers, you will be able to entrain it, right? So similarly, if you're going to be farther and farther, it will be difficult. So a lot of times, whenever there's whenever the tachycardia is already going on, so if there may be some A intervals may be irregular, so something is called as warm up phenomenon, cool down phenomenon. That is again characteristics more with the atrial tachycardia. However, if it is of course it is irregular, then AFib is the one. So one of the other important things which is important is what are the systematic approaches which we have already spoken about? So as I already said about the history about the vagal effects or the adenosine. Vagal effects is, for example, if someone is doing a shave, and during the shave, the person tachycardia tends to decrease. Otherwise, during the neck manipulations and all. So again, it is going to show more in favor for even RTs, in fact, okay, but it is going to less likely for the atrial tachycardias. Similarly, for the baseline, which we already said it about those delta waves, if it is going to be there, the dual AV pathways or the VA conduction, or even during tachycardias, you should try to look out for the VA interval, the timing, the sequence. For example, the bundle branch block, which the patient tends to develop. How is the induction, or similarly, how about the AV block, which the patient tends to deliver? Similarly, about those maneuvers which you can do with those patients. For example, like his premature PVCs or even for the RV pacing as well. And what are the response which you are going to get? Is it the VAV interval, VAAV, or the PPP